Welcome, friends. Welcome to the next session of the program. This is session 8, and the topic we are going to discuss today is very important, and that's breaking bad news. So, this is one topic, again, like I always say, very difficult to handle, but then we all know that all of us have to do this job, whether we like it or not. Do you agree with me? Yeah,
Yes, ma'am.
it happens very often. Yeah. So, going ahead, I would like to ask, first of all, what do we understand by the term bad news? If anybody would like to unmute and speak.
Bad news means it's a one like patient got cardiac arrest.
Let me increase the volume because I'm not able to listen to your listening. Give me 1 second. Yeah. Sorry, go ahead.
Bad news in the hospital means like as per the patient means when it is a cardiac arrest, and then one patient got brain death.
Sorry, I'm asking you to hold for a second. Somebody has joined using 2 devices. So there is echo. So can I request you to exit from one of the device? Okay. Yes, Mr. Kumar, I understand. In case if there's a cardiac arrest and if the
Or
patient
brain death.
yeah, or death,
Yes, ma'am.
naturally it's a bad news for the family. That's not something expected. I agree. Anybody else?
Unexpected outcome of the patient's prognosis, any
Yeah. So something that you are not expecting.
expected.
Yeah. You give a test dose to a patient and unfortunately the patient collapses.
Yeah.
We have to explain to the family. So it's a very bad news for the patient. What else? Somebody else would like to, Pauravi, what do you say?
Yeah, ma'am, bad news can differ from patient to patient and the age group. For example, if it is an obstetric patient, bad news need not necessarily mean death or something like that, but a fetal complication or complication to the newborn can also be a bad news. Apart from that, any complications occurring after surgery or on table, it can also be counted as bad news.
Absolutely. So that means it's not always death or unexpected outcome, something that you were not expecting, like in obstetrics, getting to know that there's some congenital anomaly. When you get to know, it can be bad news for the parents. Absolutely. What else? Dr. Shubha, what's your understanding of bad news?
Ma'am, a diagnosis which parents are not expecting while working with children. For example, if a child is diagnosed with celiac or T1D, then it is very difficult to disclose that disorder because the parents are most of the time either in denial or they really don't want to hear that something is wrong with the ward.
Absolutely. I think that's very true. The usual reaction is denial, where they just don't want to accept that it could be something, something serious or something that requires intervention. Absolutely. So, a lot of mental health conditions are not accepted by the family. I recently had a case. That girl has a history of, actually, they have a family history of depression. And this girl has a serious condition, but husband is not able to, accept or believe that it could be a mental health condition. So it's a bad news for the family and for the patient herself, because one, she's suffering with the problem, second, the family is not supporting and not understanding. So double problem for her.
Most of the PPD cases are this way, ma'am. Nobody wants to acknowledge the postpartum depression.
Yeah, yes. Postpartum depression is very common, and then people don't accept it, and they just kind of don't want to even acknowledge or pay serious attention. Dr. Deepa, what kind of bad news do you like have to give?
Sometimes after the surgery, some complications due to anesthesia, which was not expected actually. So sometimes sudden death due to anesthesia problems like that is very difficult for the patient's family to accept it. So breaking down the news for that, especially for young patients.
So I have seen, mothers crying when they get to know that their child has amblyopia. Because as I said, my husband has an eye clinic. And now, of course, I'm not giving much time to his clinic, but there was a time when I used to spend a lot of time in his clinic. And I've seen mothers crying when they get to know that their child is high myopic or or is amblyopic. And I've seen even people fainting. So for them, even that's a bad news. So normally we think if it is death or a complication or some serious diagnosis, that's a bad news. But honestly, uh, anything that can change the direction of your life, that can make your life difficult, is a bad news. And if I share my experience, almost like 25 years ago, I had difficulty breathing and pain in my lower, chest. So my husband took me to one of his friend, and he examined me, and he said, "Get the X-ray done. Let's see what it is." So there was some shadow that he could see. He said it could be just an infection, and hopefully it should subside, or it could be, we need to investigate her for tuberculosis. I said, take medicine for 3 to 5 days, and we get the X-ray done, and then we'll see where we stand. Trust me, those 3 or 5 days, I don't remember the exact number, they were like the whole world came crashing for me. Both my daughters were very young. My younger one was just few, I think 4 or 5 years. Elder one was 10, 11 years. I mean, for me, the whole world changed completely. Who will look after my daughters? Who will teach them? How will I feed them? Will I be able to hug them? Although we all know tuberculosis is curable and you can recover completely, and then you can lead a normal life if you're able to take a couple of precautions. But just imagine the impact it had on me. Fortunately, once I got my second X-ray done, everything was fine. My symptoms subsided. I was fine, and nothing serious happened. But just knowing that something like this can happen to me, or is one of these things, it completely changes somebody. So let's not assume that it's only death or complication or some serious thing. When somebody gets to know I'm diabetic or I have hypertension, I've seen people crying, "Oh my goodness, I can't eat sweets because I'm diabetic. I'll have to change my lifestyle. I'll have to change my food habits." So bad news could be anything, from very small thing to a very big. I agree. So, Dr. Nirankar, I know you are not able to have your camera on, which is all right. I understand. If you want, you can join from phone.
Ma'am, I tried from phone also, but there is some issue. From phone also, the camera is not working.
Okay. So maybe what happens, you have to permit Zoom to use camera when on Zoom. That's one of the settings we have to make. But it's okay. I will not now ask you to log in and log out. Let's continue like this. So
Okay, ma'am.
yeah, but if I may ask you, what kind of bad news do you normally have to give? Because I know you are in intensive care, so I want to ask you what kind of bad news normally you have to give.
Yeah, so ma'am, in intensive care, most most of the time, the patient when patient gets not healing well, or the condition deteriorates, in that cases, we used to just prime the relatives that the further problem or the further disease is not responding to the medicine,
Mhm.
and we have to take a call at certain point of time that we have to offer a patient end of life care. or situation, like in terminal stage cancer patients or very severe immunocompromised, like in transplant patients, like lung transplant, kidney transplant patient, if they are not, if the organ got rejected or something, because they have just did a transplant for like a month ago. They were all happy, okay, everything is fine now, kidney is working okay, and suddenly the rejection comes. So that phase, like from happy to sad moment, we have to tackle it very well with them. Like we have to prime from initial stage. Like day one, we come to know that this is not going to happen, but then also slowly, we try to make them understand. Okay, this is the situation, we'll try, and then once the acceptance comes, that time we have to, at one point of time with multidisciplinary team, we have to disclose that the organ got rejected, and now we have to treat in this manner, which we have with the protocol, as per the protocol. Is the thing.
I'm sure it must be really very tough
Yeah.
because one, they come to healthcare with huge hope, with very big hope that everything will be fine. And of course, there are a lot of financial concerns.
Yeah.
And then recovery and rejection is again a painful situation for them. So,
We-
so how do you prepare yourself to deal with this situation? Emotionally, how do you prepare yourself?
Yeah, that's a big challenge for us also, because in young patients, there is very difficult for us also to tell. So many times what happened when some young patient got trauma, a road traffic accident, and they came to us within an hour, we come to know there is a brain dead. And at that time, when we have to convince the patient that whatever, like lungs are fine, heart is fine, everything is okay, but brain is not working. At that time, it is very difficult. So we have a team in our hospital, a special counselor team. With them, we sit with the patient relatives, and then we initiate the talk. In multiple phases, we have to inform them.
So it must be really very challenging, especially there can be any kind of reaction.
Yeah.
Family may accept, family may not accept. They may even, get aggressive and become upset because that's not something they were expecting, and then suddenly they have to, deal with it. I'm sure it must be very, very difficult. So anybody else who would like to share their experience when you have seen breaking or bad news happening, or would you have any experience to share with all of us?
Yes.
Yeah.
Ma'am, I would like to share a personal journey, like my own experience. So when I was a child, I got diagnosed with myopia and I wasn't able to see properly. So I told my mother, and she took me to an ophthalmologist. And then the ophthalmologist said that I have myopia, and I was quite young, like I was just 8 years old at that time. So it was like bad news for my mother. She was totally upset that, I'll have to wear glasses now for the rest of my life. So what I mean to say is bad news need not be like something really major that happens to the patient. It could be small things also that make a big difference, like a teenager gets lots of pimples and acne, and then the doctor says that now the scars are not going to go and it will need a lot of treatment. That could upset, and that could sound like bad news. So even trivial things can be bad news.
Absolutely. That's what I was saying, that it's not always a major, diagnosis or complication. Small things also could be. Somebody can't conceive infertility. Again, it can be bad news for a couple. And we have seen, a lot of repercussions of these kind of situations because it's a very serious condition for them. So I was thinking that we should do a role play on one of these situations. So if anybody has a situation to suggest, we can take that up, or I can suggest a situation, whatever you say. Anybody? Can I request Dr. Kausar and others to have your camera on? Because I can see just 6 of us. All others, if you can have your camera on, that will be nice. Because when I ask questions, I want everybody to participate and answer and try to, discuss. I can see we are 10 of us. Aarti, are you there? Can I ask you to have your camera on? Kauser, can I ask you to have your camera on? Yeah, please keep your camera on, otherwise I'll forget that you're there with me. I request you to participate because it's not like passively listening, but it's important to participate and discuss. So, Costa, do you have any situation to I don't know, give us for a role play? If you have seen something or you have attended to some situation.
Ma'am, as a dentist, I can suggest one situation. Often we have road traffic accidents or we have minor accidents. And usually it is the anterior teeth that is
Yeah.
lost.
There is some network issue at your end.
And the patient, it affects switch off.
Costa, I think there's some issue at your end with network.
Yes, ma'am, it's low bandwidth every time.
Oh, okay. So all others could hear her, or it's only me who could not hear? Even you could not hear me. Also, I think there's some network issue at your end. So maybe you can keep your camera on, but suggest the situation. Can you repeat the situation, Kauser? Don't have the camera on. I know.
Ma'am,
Kauser, you can switch
Yes,
off
ma'am.
your camera. You can,
Yes, ma'am.
you can switch off your camera, but still,
Okay, thank
yeah, give us the situation. Give us the situation.
Okay.
Yeah.
One situation could be that let's just say Mr. Kishore, he's met a road traffic accident or had perhaps a minor accident. He has approached the hospital. It's a multi-specialty hospital. It means it has a dental wing as well. His vitals are stable, but he has injured he has suffered from facial trauma. He has been referred to a dentist, general dentist, and and in history they can see that his anterior teeth has suffered a loss. So the role play could be, how do you pacify a patient that is whose teeth or tooth is unsalvageable, means it has to be extracted. So how would you approach the patient? What diagnostic investigations you could do? What could be the conclusion? And if at all the case is that the teeth or the tooth cannot be saved, how are you going to help the patient understand, perhaps with an alternative treatment?
So, Kauser, have you dealt with something similar in your setup?
Yes, ma'am.
Okay. So, normally, how do patients react?
First of all, the patients, because it's the anterior tooth, they find it difficult to accept. Second, they want to know if the teeth that they have or the tooth that they have can be salvaged through temporary restoration or not. If not, then permanent restoration. And the most expensive options that they have is either fixed dentures or an implant. So there's a lot of the patient, they suffer from anxiety sometimes. Sometimes they look for immediate treatment. Sometimes they decide that maybe they will not go for a treatment.
Okay. So, is the group okay with this situation, or you want to take something more serious? I'm okay with that, but I want to know from others. Raise your hand if you're okay with taking this situation for the role play. Or if you want to suggest something else where the situation is serious. And because in this case, we all know that dentistry has really progressed massively in the couple of decades. And now we have implants and people almost like feel that they have a natural. Do you want to take something more serious than this? I'm really sorry. Yeah. So, Kaushik, thank you for offering this situation. Although I'm sure it must be difficult, especially for a new dentist, for a fresh dentist, to talk about it. And but usually, if the patient comes with road traffic accident and they have injured their anterior teeth, somewhere they can't blame the doctor or the hospital for the loss. But what happens a lot of time, there is a situation that the patient is already under your care, and unfortunately some complication develops or some new diagnosis gets identified, and the family has a tendency to blame the hospital or the doctors for negligence. They normally call it as negligence. Could we take something little more serious? So, for example, there's a lady who has been coming for antenatal checkup regularly to the hospital. Now she has come in active labor, and you can we have checked the fetal heart sound and fetal movement, and it's a case of fetal death. And you have to announce it to the lady, her husband, and her family. And she has been coming very regularly for antenatal, and all her parameters, everything was fine. There was no indication of any high risk. But all of a sudden, there was a slow, a movement. And then when she comes to the hospital, you get to realize after checking the fetal heart sound and ultrasound that it's a case of death. So, do you think we can take that situation? So, who is ready to play the role of the patient, patient's family, and doctor who is going to break the bad news? Dr. Shubhra, can I ask you to play the role of the doctor? I know it's tough. Something if we haven't done, it's very tough. But when we
Ma'am,
get,
I am not a doctor, so I might not know all the terms that I have to
okay,
announce.
fine, I agree. Dr. Deepa, can I ask you to do this? Because it has to be done by somebody who understands medicine and who can explain scientifically why did that happen. Because family is going to ask you. Everything was normal. We were coming regularly. There wasn't, we were not informed that there's any possibility of any fetal distress or that. How come all of a sudden this has happened? Are you comfortable doing that, Dr. Deepa? That's okay. You can refuse if you can't.
Yeah.
You'll do? Okay. Okay. So now we need somebody who's ready to play the role of the, if you don't want the patient, we can have the family. Maybe we can have girl's sister and husband who is ready to play the role of a sister. Poonam, can I request you to be the sister of the patient? Okay. Somebody who's ready to play the role of the husband. Dr. Santosh, can I ask you to play the role?
Am I just joined, so I didn't hear the whole assignment.
I will explain to you. So we are actually discussing Breaking Bad news. We are discussing the topic Breaking Bad. Today's topic.
Okay, so any condition the patient?
Patient had a normal pregnancy, everything fine. She was coming for regular antenatal checkup, and she has come in active labor. She did have a sluggish fetal movement in the last couple of days. Probably she didn't realize that it was something very serious. Now She has come with her husband and her sister to the hospital. And after examining, the doctor has realized that it's a case of fetal death. They could not hear any fetal heart sound. There was no movement, fetal movement. And it's a confirmed case of fetal death. And Dr. Deepa is going to play the role of the doctor. She is going to announce it to you and Poonam. So Poonam is playing the role of sister, and you are playing the role of patient's husband.
Patients?
Husband.
Okay. Okay. I will try.
So we'll all switch off our videos.
Your throat is really bad. Huh?
Very bad. I'm not able to talk. Sorry. I'm extremely sorry. Yeah. Yeah. Go ahead, please.
Hello.
Hello. Good
Yeah.
evening, Doctor.
Good
Yes.
evening. So you are Bindu's husband, right? The patient's husband, right?
Yes, sir.
Mr. Santosh.
Yeah.
And Mrs. Poonam, you are his.
Yeah, I am
her,
Bindu's sister.
Okay, right. Okay, right. So actually, how was her health yesterday and today? What happened to her actually? Can you just explain?
She was perfectly on.
She was all right?
Dr. Deepa, she
No
was
health
perfectly
problem?
all right. No
Okay, she
problem.
was saying, okay, what
Yeah.
about the baby, fetal movements and all? It was okay. She was counting
Yeah,
it and all.
till
Okay.
yesterday morning, she was having the feelings, movements were there, everything was normal. She was eating food, she was doing household work, everything was okay.
Okay.
And throughout the pregnancy, also, everything was okay. Now, what you.
So her diet, everything was fine, right?
I think my wife's health was not good for some time, so for a few days. So
Okay.
she felt lethargy kind of thing. So I think other than
was
that,
she-
we didn't
Pardon?
notice.
Pardon?
She was not feeling better for last 2-3 days.
What about her food intake? Did she have any dizziness, any severe headache or anything like that? Or
I didn't notice that. She didn't tell me, but yeah, it's the only thing that she was feeling uneasy kind of thing.
okay, right, okay, right. So until now, all the tests that were done were normal, right?
Yeah.
But she was having some health problem recently. Okay. So actually, right now, we have checked her and the
Ma'am, everything
baby.
is all right?
Yeah. So actually, I would like to tell you something. I don't know, it's really unfortunate, but you have to take the news a bit calmly. You know, it can happen in a few patients, like a few percent of patients can have this problem. And right now we have checked both the mother and the child, but you know, unfortunately, the child is having some problem. Like when we checked, there is no fetal heart sound. So we think, I'm sorry to say, we think that there was something unfortunate event that has occurred either with the mother's health recently or
Oh,
with the child.
what you are saying? What you are saying? This is not.
Yeah,
She was all right.
yeah. Actually, you know, and yeah, I know. So be calm, be patient. You know, sometimes this happens.
Oh, no.
I'm really sorry to say. See, until now she was perfectly okay, but as your brother-in-law said, she was having some health problems recently. Maybe she had some high BP, or maybe the child had some sudden like congenital disease. Actually,
No, I didn't
congenital
say that
problems
she
were
had a
not.
high BP. I didn't say she had a high BP. It was just
Okay.
that she was feeling bad thing.
No,
And every time
maybe
we
you may
come
not
to you,
have
you said
checked.
that it is okay, she's okay.
But last time when she came for checkup, she was
She
perfectly
was
all.
perfect. Yeah, sometimes you know this can
there.
happen. This can
And
happen
And you
sometimes.
told me, ma'am, you promised that you will have
she will have a
child
normal
children
delivery and
good.
everything will be fine.
Yeah.
Now you are
Sure.
saying
Yeah,
something else.
even when I saw her last time,
What happened
put the
here?
child. and the baby, but so sorry, both the mother and the baby were okay last time. But sometimes sudden change of events can occur. So maybe some congenital problems or some unknown problems could have occurred. Actually, we have not detected any congenital problems, but it can happen.
How
So
is
I'm
Bindu?
really sorry.
How's she's
She's
okay?
fine. She's fine. She's fine. She's okay. But her BP is a bit high.
Can we see her now?
Sure. You can see her. So
Ma'am, but I think I
first,
don't believe you. You should get some other doctor
You
because you promised that she will have
can
deliver a healthy baby. I don't
okay,
trust you, ma'am. You
okay,
just
can
right.
you
We
recheck,
have,
please? You
not
can
done it.
yeah,
recheck and call
we will
other
I
surely
like that
recheck.
you get
We
another
surely
doctor
recheck.
to see.
I'm calling my superior, my
What is
head of
she
the
had
superior?
a normal
department,
delivery
Last time you
last
said you were
time and
experienced
now
person. We
also.
came to you that you are very experienced person, ma'am.
Yeah, see, it's not like, maybe some unfortunate event has occurred. It can happen to
There is
some
nothing happened. I
people.
can promise you.
No,
There's
no,
nothing happened. Nothing.
She didn't have any fall, nothing was there, no?
no, no,
No
not
Nothing
at
fall.
was
all,
there,
Nothing.
not
right?
at all.
And
Okay.
everything was
And
which
throughout
was
nine
required to
months,
get
she
a healthy
was
baby. We did
perfect.
everything.
Yeah. But
Throughout
if
9 months,
if
she
you
was
if
perfect.
you
Last
like,
delivery
I'll
was
ask
perfect.
my HOD to check her.
Doctor, please
She
do.
will
Please
explain
ask her to
to
check again.
you.
We want her to
And
check.
Yeah,
and
we'll
do whatever because I mean, this is my first child. We were ready to do anything. If you ask more money, and we are ready to give you, but
see.
please
It's
save this
not
baby
it's
child.
not about the money,
You
See,
have to do something, ma'am.
see, we are doing our level
We,
best, but
no, this is very bad actually.
I'm so
We can't just,
sorry.
yeah, we can't think anything else other than this.
Okay.
Yeah.
Please do that and
Anyway,
please check it.
right.
We are ready to pay anything, any amount you want, extra money we will give you. But
No. It's
make
not
sure
about
that
the money,
we have a
It's
healthy
not about the money, please.
Again, you
You have to
recheck again.
understand.
Again, do it. Call some
Yeah,
other specialist
yeah.
also.
We'll
Check it
call
again.
our, yeah.
maybe I'm not sure if you have done something wrong while examination that something has hurt it. So we'll
No. She
please,
was
yeah.
just brought here, no? So it's not like that. She was in labor. She was
Because I
having
was hearing
pain.
when you were examining, I was hearing that two nurses were whispering and they said, Ki, don't tell this to your patient relative and all that. So we were hearing something. So we want that. Please check and make
Uh,
sure that
no. It's nothing like
you
that.
save the baby's life.
She was having premature labor. I mean, she was having all the pain, but
Because they were whispering. When they came, they smiled also and they're whispering also. Please make sure, yeah.
No. It's not like that. See, anyway, I'll ask my superior to check the mother, okay? And
Yes,
I'm going
please
on
check
the,
it
be
soon
calm.
and let us know. Let us know at the earliest. Please check it
I'm going
soon.
to
And
call my friend who is a commissioner of police. I'm going to call him, but please
this
make
is
sure that
really
no
bad
bad
news
news
for
will
us.
come.
Really, this you are giving
Yeah.
us a very
Anyway,
wrong.
They will be devastated if that's happen.
anyway, just try
Please,
to understand
please check it
and
immediately. Check it again.
sure.
And let us
And
know. Let us.
don't tell
We'll
this to
do
my wife
whatever
because
we can.
she will go berserk. She will just like she can't tolerate this news. So before
Don't tell
that,
to the
yeah, just before that, you please get your senior to
mother.
Yeah, sure.
examine.
We are just
Yeah.
calling our doctor, senior doctor. She's coming soon. Just be patient. Okay, we'll try to.
And take care of Bindu.
Sure. We'll do.
So take care of Bindu also.
Yeah, sure.
Please.
Ma'am.
Can I request everyone to come in? I know I put you in a tight position. So, how did it feel to be there, Bindu, Deepa?
Ma'am, this situation was really tough because, when it comes to the baby and the mother, it's really a very sensitive thing for the whole family and for the doctor also, uh, the family's expectations and everything, it crashes down when they hear that the baby they were expecting was 9 months or even 7 months, if they lose the child, really, it's very difficult to face. And the doctors also having a tough time to tell the truth.
That means it's really very difficult.
Very tough.
So I think for all of us that should be something we should appreciate, that obstetricians have to really go through hell when they have to talk about all this with the patient or their family. Somebody's device is on. Somebody has joined with iPhone. I can see iPhone, I can't see your name. Okay. I want to know from the family, if it was a real life case, what would have you felt, or what could have been your concerns?
It is
Even-
really very
even-
difficult to accept.
Yeah.
So,
And
any,
you really angry on the staff and the hospital authorities, how this has happened. For the last 9 months, there was no problem, and at the last, they are saying they might be doing, there must be some fault at their end also. They are not disclosing it. So many doubts come into the mind, and you feel really aggressive and very, very bad.
so
Yeah, and then you start doubting that maybe doctor did something, because 2 days ago there was a policeman in UP. He went to the CSC. He felt uneasy. He went to CSC, and doctor there on duty gave an injection, and within 10 minutes the patient died. So now people started saying that because the wrong treatment patient died, but actually it was as per protocol she did that. So this is kind of anything come up in the mind. It depends on the in what mood and social background the person comes. It's very difficult for the family to see that baby going to come and then having this bad news.
So I think now you get to see both perspectives. So when you played the role of a gynecologist, you saw how difficult it is to do this job. And when you acted as a patient's family, you immediately started having doubt that maybe you haven't done your job well, maybe you did not check her properly, maybe you did not notice the signs and symptoms of distress. You could have informed us, you could have told us in advance, we could have taken her to a better hospital, we could have taken second opinion. So many things came to your mind. That's how even the patient family's mind operates in that moment. I want to know from the audience.
You
From,
lose interest absolutely from the hospital.
yeah,
Such thing happens.
you lose trust, absolutely. So I want to know from all others, from Mr. Anand, Ms. Rose, Shubhra, and Aarti, are you there? There are a couple of people who are there, but they are not visible here. So, what is your takeaway from this role play? What is the learning from this role play? One by one, if you can share your.
So whenever we are speaking to the attenders or the patient concern, we should be confident, and we should not like speak any wrong things. Like the words what we are speaking should be perfect. There shouldn't be any miscommunication. After full study of the case sheet only, then only we need to speak with her. Half
That
of the
we
things,
should really know the case well. We should
half
know.
of the things we know, half of the things we should not speak.
Yeah.
There will be a very like big blast will happen. Suppose if we speak anything like unwanted things and all. So we should be very careful when we are speaking with attendants.
Thank you. What about others? What's your take?
Ma'am, I feel that whenever, because I faced a similar scare in my own journey, my pregnancy, the last moment. So what I feel is whenever a doctor might be coming from a very logical and very like good intention, but when they try to resist the emotion of a patient, then the blame starts shifting towards the doctor. So what a little practice that I'm doing, what I try to do with even nutrition patients, when there is some unfavorable or undesirable diagnosis, I let them vent first, because then I actually get an idea about what they're angry for. Because in this situation also, eventually the blame started shifting on the doctor, that okay, some of the nurses were talking about this. Once you let the patient vent, obviously they are like disappointed or disillusioned. They start talking about all the things that are coming to their mind. Then one by one you can tackle the emotion, because obviously this is such a situation where you anything you say won't work, because the patient is in that state of mind, so you have to leave the patient with that disappointment only. but at least you have to let the patient vent out so that they are a little at ease and like they pass that denial phase to accept what has actually happened.
So that means initially everybody will react in more or less similar manner. They
Yeah.
will not accept it, or they would like to blame the hospital or the doctors or the nurses or the staff. They may even try to find fault with us. That's a very usual way. But then slowly when the heat, kind of cools down, then like for example, when Poonam started saying, is Bindu okay? Can I see her? Can we go and meet her? That means now your focus shifts on the welfare of the mother. We have understood that we have lost the child, but is the mother okay? And then, like Dr. Santosh said, don't tell her, otherwise she'll go berserk, and we don't want to give her a shock. So we will tell her slowly, but don't tell her immediately. So that means now their focus has shifted from the death of the fetus to the mother's welfare. And that's how the human mind functions when we have any trauma or any loss. The first is that we cry over the loss, and then we say, what do we have and what can we salvage? And then we try to work on that this thing. But for that, we need to, in that situation, whoever is, whether you are a doctor or a nurse or a clinician or a manager or wherever you are, whatever you are. So that means you will have to give that much of time to the patient's family or to the patient to vent and then cool down and then start thinking rational. But what happens when they start blaming us or when they start finding fault with us? We also become aggressive and we start arguing and we start defending ourselves and we start giving them answer. Like for example, in this case, I mean, good. Thankfully, Dr. Deepa didn't say this, that you brought her late. You should have brought her earlier. Why did she not realize that there was less fetal movement? Every mother gets to know that when there is no fetal movement, how could she miss it? I mean, that's her fault. She should have known. Now, see, the moment you will start blaming the mother, they will start blaming you and they'll find more fault with you. And that becomes more like a conflict and it can escalate. And that means in the whole situation, we have to know that I have to let them vent and I have to control my emotions and I have to handle their emotions and not react to every situation. And then when they calm down and they are in that, space where they're ready to now have a kind of a dialogue with you, that's where you need to really, take it forward. Any other point from others who are Dr. Nirankar, if you can share your thoughts. Rose, if you want to say something. Or any other person like Dr. Deepa, if you have something more to share from your point of view, please feel free. Rose, do you have something to add? Do you want to ask something about it?
Yes, ma'am. I would just like to add on to not to be more aggressive with the patient because these situations and all mostly occur in my state. And when the patient and the parties, like when they are not happy with the doctor, then they'll come as a mob and they will even destroy the hospital and all. So I really love the fact that not go into aggressive mode and address their concern and acknowledge. Yeah.
So if I say what is my takeaway from this role play is, see, we normally think everything is fine and it will be all right. And therefore we don't talk of anything which can, turn upside down. And obstetrics is one branch where everything might go perfectly all right. And at the last moment, there's a cord around the neck. And you lost it. I've had a case in my own relation. The woman had amniotic fluid embolism. Although it is one of the rarest complications. I think, if I go by statistics, it's once in a lifetime a gynecologist gets to see a case of amniotic fluid embolism. That rare is the incident. Unfortunately, that happened in one of my relatives' case. So even the gynecologist is not prepared to identify and then talk about it to the family. And how do you explain that it's not my fault, it's patient's physiology that misfired. And that happened. So the whole, from this role play, my learning would be never say everything is all right and it is completely safe. somewhere in a very subtle way, you need to prepare the family. See, obstetrics is one branch. Child is fine. We are keeping an eye on it. We are doing antenatal examination. We are checking the weight. We are doing regular ultrasound. We are checking fetal heart sound. But when the active labor starts, what happens? It's very difficult to tell right now. So let's keep our fingers crossed. We'll keep an eye on the mother and the child and hope we'll pass through this. So somewhere that 1% of awareness has to be created, that it's very, very risky. There is a possibility of something like this. Like, for example, Dr. Nirankar was sharing about the transplant, lung transplant, kidney transplant. We all know there is a risk of rejection. But if we have not talked about rejection, it will be very difficult for you to justify why did rejection happen? How can rejection, isn't it? So we have to talk about that part, so that they know that there is a possibility. But just giving them a very, rosy picture, everything is fine, and we are taking our families, organs, so there's no likelihood of rejection. And when it happens, it becomes very difficult to explain why it happens. So today's the discussion and the role play, I'm going to now take it towards the protocol. How do you go about it? There are a lot of protocols available to tell us how do you go about breaking bad news. But these protocols are more like guidelines. Each one of us will have to design our own way of handling a situation. Which other models do you know? Or which other framework do you know? I think one is very common, that is Spikes. Spikes model, I think most of the people know. How many of you know Spikes as a framework for breaking bad news? Raise your hand. How many of you have heard Spikes as a model, as a framework? No. Dr. Santosh knows. But what others? No. That's okay. We are going to talk about it, so you will get to know. So I'll take you through the presentation, and of course we can continue having the discussion. Let me share these slides and take it further. I hope the presentation is visible to all of you. Okay.
Yes.
Yeah. So we did discuss what is bad news, and we did realize that just death or complication is not bad news. Even simple diagnosis can be bad news for the patient or their family. Now, for example, if you tell any parent that your child has a cognitive deficit, or probably it's a case of low IQ, it can be a huge setback to the family. Your child has autism, it can be a huge setback to the family. So it's something that will completely change their life forever, because it requires, changing their way of life, bringing a lot of changes in their lifestyle, and it has a huge impact on the family and the society also. So we have talked about these questions, how you handle, how you prepare yourself, and we also went through this role play. And I'm sure each one of us got to see how it impacts not just the family, but also the doctor who has to do this role. So this is one slide I'm sure you must have seen sometimes, Here, the patient died after a situation, and the family is carrying the diseased body and a banner in front of it, where they are kind of blaming the doctor for the reason for the death. They are blaming that this is doctor's fault, and that's why the patient has kind of died. I'm not sure if actually any error happened, but I'm very sure that there was some lacunae in communication, in preparation, in kind of priming them for what is going to happen. And whenever we fail to do this, And whenever we talk about it, it comes as a shock for the family. And that's where the aggressive reaction comes in. So therefore, breaking of bad news should always be, it's a very difficult and trickiest communication, because it's something where you will see aggressive reaction coming from the patient party. And we all know the immediate reaction is denial and anger, which you will not deny. So most of the patients want the communication to be made in a very transparent manner, but at the same time, it should be, communicated in an empathetic manner, because they feel that, of course, you have to tell the truth, but let it be more, humane when you are telling them. For example, in the role play we saw, there was a point when Dr. Bas said, sometimes these things happens. For us, probably it could be a very, very casual way of saying, but for family, it may not be something that they were expecting. So it can come as a shock. Studies have also shown that almost in 2/3 of the cases, the patients and the family members have reported that the breaking bad news encounter was suboptimal. Clinicians sometimes are very straightforward and they come out as being blunt. Sometimes the place where we break the bad news is not appropriate. A lot of time we do it in front of the patient, and we know sometimes the family says, we don't want the patient to know, or we want to tell the patient later. So, or it could be that you are doing it in an open place, especially, for example, outside OT, outside ICU, outside labor room. There could be others who are overhearing the conversation, and when especially it ensues into an argument, it can have serious consequences. A lot of time when we break the news in a blunt manner, patient might get this feeling that there is no hope and we have lost everything. And especially, for example, in cancer cases, we know the way we say it might sound to the patient that probably this is the end of life. So they do want the doctor to be sensitive, to be honest and transparent, but at the same time, they expect the clinician to be sensitive because you are dealing with emotion. So somewhere the patient and the family expects that we will align ourselves with their emotional milieu and we will manage the situation in a more sensitive manner. Younger generation doctors sometimes experience more challenges. One, because they have still not seen a lot of cases. They have not learned how to go about doing it. There is no formal training, we all know. As yet, we haven't had any formal program where all doctors, all nurses, all healthcare professionals learn how to go about breaking bad news. And then they don't even know what can actually prevent extreme reaction coming from the patient or the family. And of course, we all know that breaking of bad news require advanced level of communication skills, where you really need to have wonderful, experience in handling your own emotion and emotions of others. For example, what to say, what not to say. Now, I can share one experience. I mean, it's from one of the Delhi government hospitals. And we normally say it's the younger doctors who have challenge in, selecting the right words or being more compassionate in their discussion. So this was a case of road traffic accident, and a young boy who was actually on his way to distribute his sister's wedding card. So unfortunately, on the way, he meets with an accident and he dies, on the spot. So his dead body is brought to the nearby hospital, and the family is informed. The family comes in. Now, because it's a road traffic accident case, so the body had to go for postmortem. The family initially requested to not do postmortem, like usually patients have. I mean, diseased families, they don't want the postmortem to be done because they don't expect any foul play, but the law says the postmortem has to be done. But then They were also informed that it will be done tomorrow morning. It's not possible to do today because they don't have doctors around. So it will be done tomorrow and the body will be in the mortuary for tonight. Now this family goes to the medical superintendent of the hospital with the request कि सर आज करवा दीजिए, अगर करना ही है, first request is कि don't do it, but in case if it has to be done, then we request that do it today so that we can, take the body home and then cremate and then think what to do about the marriage was planned. Can you believe the words that came from the medical superintendent's mouth was, I'll first say in Hindi and then I'll explain in English. He said, देख लो मिट्टी है, चाहे आज करवा लो चाहे कल करवा लो. And if I say in English, it's more like he's already dead. It doesn't make a difference whether you get the postmortem done today or you get it done tomorrow. Now imagine a family has lost a young boy. No disease, no any health condition, unfortunately meets with an accident and they lose this boy. Over and above that, if that's the way we are responding to their request, we can well imagine what must have happened after this. So one really requires wonderful control on the language, the words that you use, because they can really be very, very, traumatic for the family. Of course, you have to learn to handle emotions and the questions that you can expect coming from them. And then how do you go about handling that situation? So a word of advice that I normally give to everyone who is in healthcare, please build good rapport with the patient and their family, because you never know which condition might turn into an emergency and have an unanticipated outcome. We have seen cases where patients have lost their life just with test dose. I mean, something that you don't expect. I've seen a case who came for post-operative follow-up and he collapsed. So, I mean, there's not always a very clear indication that the patient might die, especially if the patient is doing well. But if you have good rapport with the patient and their family, how do you do that? Because studies have shown that patients and their family are less likely to be aggressive if they're familiar with. And if you can create familiarity by regularly updating them. For example, if the patient is in ICU, and if it is day 2 of the ICU, we have to know the primary caretakers, who are the immediate family members. We have to regularly update them. We have to prepare them for the eventuality, especially when the condition is not stable, especially when there's a possibility of deterioration, and the patient may not make it. So it's better to regularly update them so that they mentally get ready, the family gets ready. A lot of time they'll come to you, with concerns. That's an opportunity to build rapport with them, to answer their questions, to show them that you are doing what best can be done and is being done. You are following standard treatment protocol and you are doing your best. And then it's always good to involve them in decision making. For example, if the patient requires ventilator, if you are preparing them, right from the beginning, that in case if the condition deteriorates, so you might have to put the patient on ventilator. So asking them, are you okay with it? Because that's the call you have to take. So once you engage them in decision making, they somewhere feel that yes, they knew about it, they were informed, and they were part of the decision making. Let's remember, whenever the patient is critical or has a serious diagnosis, the family is looming under the greatest fear, and that is fear of death. And studies have shown that we look after the patient very well, but when it comes to managing patients' families, emotions, probably we don't consider them as the beneficiary of our care. and we don't attend to their request or their concerns very meticulously. It is the patient's family who's probably suffering equally. Patient still has a bed, is getting care, attention, medical care, medicines, nursing care. It is the family who is running from plate pillar to post. So it's very important to address their emotions and their concern and involve them in decision making. And that will kind of prepare them, and it will not come as a shock for the family. Of course, there are situations when even you do not know that this is a possibility. But in a lot of situations, we have a fair idea about the prognosis. At least in those cases, we can prepare them and minimize the shock that they might suffer. So I'm going to share a protocol of breaking bad news with you. As I said, there are a lot of protocols available. Spikes is one. The one which I'm going to share with you is 4Ps, but it is very similar to spikes. So one thing that I always say, whenever there is a critical condition, updating the family and breaking of bad news should always be done by the senior most person present in this system. Juniors can be present, but they should actually be more like observers. It's a good learning opportunity for them. But the breaking of bad news should always be done by the senior most person. So the 4Ps model or the format I was talking about, it is first P is preparation. And preparation is not just for the doctor, but also for the place where you are going to do it, and also for the patient. Next P is performance. How do you go about doing it? Third P is palliate. How do you palliate the situation and the person? And then the plan. What is the plan of action? So when it comes to the first P, that is preparation of the physician, it's very important that you actually know and confirm all the facts. Whenever you are going to break the news to the patient or their family member, never go unprepared. Know what all has been done, what investigations has been done, what are the options available now, what are the risks in each option, what do you recommend, what are the possibilities. If you know them thoroughly, because they are going to ask you a lot of questions. Anywhere you fumble or you appear inconfident or you appear that you are not aware, they are going to lose trust in you. It's very important to make sure that you know every small detail about the patient condition. There is no harm going through the complete case sheet once again, because in the beginning situation could have been different than from now. So know every bit of it so that whatever they ask or discuss, you sound in the know of it and you sound confident. Usually it's always good to go and greet them and make connection with them. It was nice when Dr. Deepa, when she started talking to the family, and she just asked, how was she feeling in the last few days? So that was a very good way to make the beginning of the discussion, because she didn't straight away start with, I'm sorry to tell you that there is fetal death. But she first tried to know how much does the family know. Do they have some idea about the patient's condition? Could they notice anything which was unusual in the patient condition? So when you start with that, you get an idea how ready are they. Then of course it can be a 5 minutes job or it can be 15 minutes job. So please be mentally ready to spend some time. If you appear to be in hurry or you have something waiting for you, the family is going to sense it, and they're going to feel that you are not giving them 100% of attention. So at that moment, it is very important to give them complete attention and your full, discussion with them. So be mentally ready to spend time. In between, phone calls and visitors will have to be managed. Maybe you need to put your phone on silent mode, and whatever calls come in, either you just briefly say, I'm in a meeting, I'll call you later, or you give your phone to one of your colleagues and ask them to talk to the person. But in between, talking to somebody is not acceptable, not going to help you. Somebody coming in with some file for signature, for some consultation, for some discussion, again, is not a good idea. So make sure that you manage these interruptions, in advance, so that in between you are not disturbed during the discussion. As I said earlier, please do not delegate to your juniors. I've seen this happening a lot of times. Seniors, they'll ask their resident to do it, they'll ask their junior to do it. That's not a wonderful idea, because maybe they will not be able to handle this situation very effectively. Coming to the preparation of place, as I said, especially in government setup, we don't have a separate counseling room. Not everywhere, I mean. So a lot of time we have seen people doing it outside in the corridor, or the outside OT, outside labor room, outside ICU. It's very unsafe to do this exercise in an open place. One, everybody reacts differently when they are being observed by others. So you might react differently, the patient might react differently. Plus, others who are just bystanders, they can also start intervening and can fuel the situation. So it's always advisable to sit down at a separate place and ensure privacy for the patient and also for you. So you can involve a couple of people. For example, in the family, there could be somebody who appear to be, little senior and calmer and more experienced. You can have them in the discussion. From your side, you can ask one of your colleagues to join you. You can have your counselors if you have that set up. You can have social workers if you have that kind of arrangement. Even a senior nurse can be of great help to you, because by now I'm sure she must have learned how to handle emotion. Even simple things like having a facial tissue or a glass of water can be a very good gesture. If somebody is crying, and because once you break the bad news, there's a possibility they may start crying. They're not carrying a tissue or a hanky. So naturally, they'll feel uncomfortable if you at that moment provide a tissue paper or offer them a glass of water. Kinds of help them go through that situation. Now coming to the preparation. So before you start talking about anything, it's very important to assess how much they know, how ready they are for the news. So for example, in this case, that the role play that we played, if they were referred by another hospital, so that means they have an idea that probably there's no fetal movement. Or the lady herself reported that for the last 2 days, I had a feeling that fetal movement is not okay. So that means they have at least some idea. So when you ask them, so what do you think, what exactly happened? Or what has your referring doctor told you? Or what is your understanding of the situation? So from their answer, you will get an idea how much prepared they are. At the same time, it's very important to check the patient's information. A lot of time you will see the family might straight away instruct you, please don't tell anything to the patient. Or even the patient might tell you that please don't share this information with my family. So I know in my husband's clinic, a lot of time, a lady would come in, newlywed girl, high myopic. She would come in, she's using contact lenses. And she will tell my husband, please don't tell my husband that I'm using this high power of spectacles. So we have to respect her decision. Infertility. A lot of time the couple don't want to inform the family. They don't even want their parents to know that there's a case of infertility. So it's very important to know whom does the patient want to share information. I know we are not in habit of straight away asking this question, but you will have to sense it. You will have to ask in a subtle manner and ask, how much do you want to know? Sometimes patients say, don't tell me, please talk to my husband and inform or tell my family. So that means they are not comfortable receiving the information firsthand. But anywhere, if you see that they are not, ready to receive the information, or they appear very apprehensive, or they appear very confused, so it's better to reschedule it. Not like for a very long time, you can postpone it, but make sure that there is somebody whom the patient would like to be around, or whom the patient would like to participate in discussion. And if you see they are not ready, so usually I know in ICU, we never announce death all of a sudden. So we start the deterioration and let them see, we allow them to, try to interact with the patient. They start getting that feeling that patient is not improving, patient is not responding, patient is not opening eyes, patient is not listening. So they start having that feeling. So that's also another way of preparing the family for something like this. As I said earlier, also ask the patient whom all would they like to engage in the discussion. That will give you an idea of whom they want to share the information and where they want to avoid things. So when it comes to assessing patient's perception, a lot of time you will be able to identify something like illness denial and not ready to accept. Or there's a wishful thinking. Everything is all right. I will be fine. There is no problem. I have come to you earlier also, and I'm sure you will be able to manage the situation. They may have unrealistic expectation of it. So when you identify something like this, it's very important to address them appropriately. Don't let this go without address. So it's important in case if they think, no, this cannot happen, you will have to kind of discuss, like for example, in the role play that we saw, Dr. Santosh kept saying, take as much money as you want, or call your seniors, because that's denial. We don't want to accept. We are not ready to believe. And there's a wishful thinking, if senior doctor will see, probably she will be able to provide us a solution. So when you identify something like this, of course, Dr. Diva very gracefully said, I've already called my senior. She's going to come and see you. But at the same time, if she said, see, we have done ultrasound, we have checked fetal heart sound, but there's no sign of fetal heart sound, but we will do it, check it once again. So it's important to address, that appropriately. So here again, I can share another real life experience that happened in one of the government hospitals. So a young boy, it was a kid actually, who was flying kite. Unfortunately, he touched, cooler, and it had electric current passing through it. It had a live wire. Unfortunately, this boy got electrocuted. Now the family and all neighbors, they brought the boy to the nearby hospital. It was a government hospital. So it was actually a case of broad death. But as the protocol says, they tried to resuscitate the child. They did CPR. They tried everything possible. And then they announced, I'm sorry, we can't save the child. So, and this family goes out. They have agreed, they've accepted. They go out, but outside somebody from their known to or acquaintances, go inside and ask the doctor to try once again, ask him to do CPR once again. Maybe we have seen cases where after some time, for 15-20 minutes or after half an hour, when you do CPR, we are able to resuscitate this. Now this family, there's a denial of death. There's a wishful thinking that maybe doctors try once again, they will be able to bring back our child. And of course, there's an unrealistic expectation. They came in, they requested the residents who were in the emergency department. Now, if you are not able to identify these things and you react differently, consequences will be very different. The resident on duty said, I have tried it for half an hour and there is nothing in your boy. Am I a doctor or you are a doctor? And if you are not happy, you can do it yourself. Try yourself. Now you can well imagine what must have happened after it. So illness denial, wishful thinking, unrealistic expectation, again, these are cognitive processes, cushions to soften the blow. And we can't be blunt in that situation. There was a mob attack on that resident, not only on him, all doctors in that place were very badly thrashed. So we have to learn to address even these unrealistic expectations or denials that are realistic, and then correct misinformation. Worst come worst, if you see the family is not able to accept, what if you did the CPR once again to satisfy them? They would have been very thankful to you that on our request, you did it once. So one has to really be vigilant of the consequences of unprofessional way of handling these things. And of course, tailor the bad news, like I said, we never say straight away. It's always initially the family's pride, then we share the information. When it comes to performance, so when you're announcing something very serious, it's important to be sensitive, but at the same time, you will have to tell it in a straightforward way. Do not try to minimize the severity, because you may be thinking that I want to soften the blow, but it will create vagueness and confusion. So when you say, pulse nahi hai, सांस नहीं आ रही है, we have tried CPR, we are doing it, there is a possibility, but then we are not very sure. So you are confusing them. If you are announcing that, if you are announcing something very serious, if you have already confirmed it, you will have to say this in a straightforward manner, but of course in a sense. So balancing between sensitivity and honesty is an art that we all have to learn. When you are talking about that situation, make sure that you use simple language which the patient can understand. They can exactly take the meaning. Avoid technical jargon. Something like when you say CPR kar rahe hain. So CPR, you know. How does the family know? Cardiac arrest hua hai. You know, they may not understand. So use simple language, avoid all technical jargons. Also, don't make it a monologue kind of thing. A lot of time we just say, speak, and speak. And even in between when they try asking something or clarifying something, I have seen it personally, doctors saying, पहले मेरी पूरी बात सुन लीजिए, फिर सवाल करिए. पहले मेरी बात मुझे कहने दीजिए. That's not a good idea. If they have a question, if they have a doubt, if they want to ask something, it is better to let them talk. One is they get a chance to speak. Plus, you will get an idea of what they are thinking or feeling. Are they believing? Are they listening? Are they understanding? So it's always good to make it a dialogue. Therefore, please pause frequently, giving them a chance to assimilate, because ultimately what you're saying is something very new. They have not heard earlier. They're listening probably for the first time. So they may not understand some terms. They may take time to even assimilate the information. So pause frequently, and at that moment, your body language plays a very. So if you are sitting in an authority position like this, or if you're rocking in the chair, they will not feel that you are actually with them in that painful situation. And it's also very important to check for it. You must have seen, you say everything, and in the end, they will say, Doctor Sahab, bach to jayega na. That means they have not understood the seriousness of the situation, or there is a strong denial. Now, coming to the body language, please remember in these situations, especially when person is emotionally overwhelmed, is focusing less on your words. His focus is on your body language, facial expression, and your tone of voice. So make sure that your body language and your tone of voice is congruent, and it is helpful in handling the situation. So some of the things that we can keep in mind when we are doing this exercise, like greeting softly, introducing, I saw Dr. Deepa introduced herself and she took Poonam's and Dr. Santosh's introduction. That was a good way to start, because you are kind of confirming, am I talking to Poonam or am I talking to somebody else? Am I talking to patient's husband or am I talking to somebody else? So greeting and introduction is very important, especially if there is a possibility of a doubt. At this moment, establishing eye contact is very, very important. When you don't make eye contact, what do you think somebody might take this as? If you don't make eye contact by talking to the family, what do you think the family or the patient
We are
might?
hiding the
Yes, we are hiding something. What else?
Something fishy, they'll feel like there's something fishy.
Something fishy.
And then confidence level of the patient, like the trusting of patients also will get down.
Will go down. They will lose trust in you. They may feel that you are inconfident or you're hiding something, or probably you are guilty of the situation. So at that moment, establishing eye contact is very, very key. Again, maintain open posture when you look relaxed, but at the same time, professional in your effort. Leaning forward is a good way that shows that you are trying to, you know the seriousness of the situation. You know you are into a serious dialogue and you want to reach out to them. So leaning forward communicates your positive approach towards them. As I said earlier also, tone of voice plays very big role. Anywhere if you sound authoritative, intimidating, rude, aggressive, rash, so even your speed of talking, in one side it might appear to be being inconfident or desperate. On the other side, it might show that you're just finishing your duty and you're not really understanding the seriousness of the situation. As I said earlier also, in between, they would like to definitely, say something, or ask you something, or just might express their emotions. It's always helpful to allow them to express. And when they are talking about whatever they want to say, when you listen attentively, that shows that you take their words seriously and you're listening to what they're saying and you're understanding. So at that moment, your facial expressions and body language should communicate that yes, I'm with you, I'm understanding. So when you nod, that shows that you are agreeing with them, you understand what they are doing. Emotional reactions are very, very common. If you can accept emotional reaction without being too reactive, trust me, that will help them to calm down sooner. The moment you will start reacting to their emotions, especially when you find them inappropriate or unjustified, that's going to ensue into conflict. So letting them vent their emotions without actually, confronting them or without opposing them or rejecting them will help them just express and then calm down. Comforting the patient or the family with appropriate verbal and non-verbal gesture. So silence is one good way of comforting. Nodding is another good way of comforting. A lot of time when you touch on the patient's forehead or you touch on their head or on their shoulder, that can be comforting, but then you have to be very careful. You really have to be very sure that this will be seen as a comforting gesture and not as a controlling gesture. Some people do not like to be touched when they are emotionally charged. So we have to be very, very careful. Touching an opposite sex person may not be taken well by the other party. So we have to be really very, very careful when you are going to do that. But yes, comforting on the head, on the shoulder, on the forearm, these are sensitive areas. they really get calm if somebody comforts. So these are different ways that can help us handle the situation in an impactful manner. Now coming to how do you start the conversation? By the way, what all do we say normally? How do we start in Indian context? Anybody? Dr. Nirankar, are you there?
Yes, ma'am.
So how do you normally start the conversation? Suppose if you have to, for example, announce rejection or maybe even death. So how do you start the conversation?
So, ma'am, we have a separate room for the counseling where there is a video and audio recording is going on, and that has been mentioned in the front lamp. So once we take the relative to that room with the treating team like myself, my colleague, and the immediate next relative of the patient, we sit over there, and then first we just greet them and uh, make them comfortable, and then we start like from last few days, as you know that this patient or the family your family member is having so and so condition, and today morning we are updating you that these all are these conditions and everything is going on the worsen part. Right now the situation is came that the pressures are not holding, the heart rate is not coming up, patient body like her patient body is not responding very well to the given treatment. And as we have saw in half an hour before at the bedside when you came there, we have shown you that this all parameters that so many medicines are going on, but those medicines are not helping us. So we recollect all the things which we have explained them previously. So he is also in the same page, and then we start like there's like after trying so much, the medicine is not responding, and right now the stages come where we we start in this way that the stages came now, and now we have to really think, do we continue with this same medicine, or do you have another like other your family member or other like your combined discussion with your mother or any of the family member that you want to come and sit next to patient, you have to be with them, because at any sudden point of time if heartbeat stops, then what we have to do we really want that we go aggressively with all this treatment? You know that so much pain and everything is has been like patient is getting with all this thing. So they are kind of like many of the time the relatives are like okay fine, they understand well, and they ask us that can we sit with them or can we play some spiritual music next to the patient, and we allow them with special permission, and calmly they sit over there, and once that moment come, at that time we just tell them like right now the beats are going down, uh, just we want you to sit in outside like counseling room, and we'll try to do what we can do, which officially we cannot say that we are not going to give CPR or something, because that is our mutual talk between relatives and us, that they also don't want that in the last stage we go with this CPR and everything. So calmly and everything in case to case basis, such communication comes, they accept well, we allow them, they sit over there, and this type of a conversation if we have built up from day one or like from the deterioration start, then the conversation goes very smooth, and they are also okay with, and they also accept that we have also tried very well, and uh, the disease itself is very notorious that patient is not recover.
Wonderful. Thank you so much, Dr. Nirankar. I think you summarized the whole thing very well. And if this is how we prepare the family for this, I think most of the aggressive reactions can be prevented, because if you have prepared them, if you have informed them, if you have shown them, and in case if they want to go for second opinion or if they want you to talk to any of their, you know, doctor known to them, maybe family member or a friend. And if
Yeah.
you're able to explain all that to them, I think they are okay. That whatever best could be done to save the patient, that has been. Thank you so much for sharing that for all of us. So coming back to how do you go about starting the conversation? So it is more like how do you actually begin? So although what is suggested in these statements is more like Western way of doing it, but yes, it also shows that you don't straight away go and say कि आपकी report खराब आई है या आपका ये चीज गलत है. So when you say something like this, I'm sorry, I have a something serious to share with you, or I have some bad news to share with you. So in a way, you are priming them for that moment. Or when you say that unfortunately I got some bad news to tell you, and I need some of your family members to sit with me and discuss, and I want to tell you. So that means that's how you are kind of starting the discussion. So it could be about cancer, or it could be about death, it could be about complication. And that's how when you start, it kind of shows your human side. That's the whole idea about it. Now, question is, how does bad news hit the patient? Usually you will see when you say something like this, it actually leads to cognitive, behavioral, or emotional deficit. That means they suddenly become confused. They don't know how do I process. Behaviorally also, they may suddenly sit down, they may start hitting themselves, they may start hitting the wall. That's again because they don't know how do I behaviorally react to. And emotionally, sometimes they will suddenly become quiet. Somebody might start crying, somebody might start shouting. So again, because for a minute, it's like they don't know what do I do, how do I handle it. See, we can't change the news. Whatever has to be said, that has to be done. But definitely, we can either make it, easy for them to process it, or we can make it worse by giving a cold behavior. So in this situation, if we appear, expressionless, or we appear cold or distant, so definitely they can sense that also. You will see patients may react by crying or suddenly becoming silent, or they may ask you, are you sure? Or is the report correct? Is this my report? Have you got it rechecked? Or, as I said earlier, also, some people might say, don't tell my husband, don't tell my wife, don't tell my family. Family might say, don't tell the patient. So these are the different ways the patient or the family might react to the news. This psychological response is called DAVDA. DAVDA is denial, anger, bargaining, depression, acceptance. So denial is initially they will be shocked, where there is a kind of a unwillingness to accept it. They say, it's not. So I think you are mistaken. That's not my report. Then they may be angry, either with you or with the system or with the hospital or with the patient. They may sound very unhappy. They may even become aggressive. They may even become revengeful, where they may say you are responsible because they want to blame somebody. And then comes the stage bargaining. So where they may say, how much ever money you want, I'm ready to spend. Please save my patient. Can I take my patient to another hospital? Please call your senior doctor to come and look at the patient. So that's where they are trying to, bargain and do whatever best can be done to salvage the situation. But once the reality sets in, they become quiet. So it's not a clinical depression we are talking about. It's like behaviorally they become quiet. They'll sit down, they may appear very sad, they may even momentarily become non-communicative, but then slowly they start accepting, and then they may come back to you for a dialogue and asking you, now what next? What can be done? How can we save this situation? or whatever is can be saved then. So how do we go about dealing with Davda? Denial has to be dealt with information. So for example, if it's a case of fetal death and they say that it's impossible, I think you're mistaken. So probably there you will have to let them know that you have checked the fetal ultrasound, you have done ultrasound, you have tried to, auscultate. So with information, you can help them see. Or if it's a case of cancer, if they are denying, then when you show them their MRI report and you show them their biopsy report, that's where they start understanding what is the truth. When they sound aggressive and angry, it's very important to stay calm and let them vent. You can listen to what they are saying and you can try to calm them down. But only if you think you can manage it. When they are not able to, once they have realized, but they start, they bargain with you, they are ready to spend money, they are ready to take the patient to other hospital. More than anything, I think empathy will help here, because that's where you need to understand that they're finding it hard to accept. So help them see the reality, give them time to calm down and assert without being aggressive. When they look quiet or sad or non-communicative, that's where you need to give them direction, what next has to be done. And then if you see them accepting, that's when you have to encourage them to take it further and take the next step that needs to be done. So in all situations, I think empathy plays a very big role. If you can see things from their point of view, 9 months, everything will well. All antenatal checkups done properly. And over and above that, if it is a precious child, imagine what must be the families. And in every case, I think empathy is something that really helps us to see things from the family and the patient's point of view. So you can also express empathy by being quiet, but also there are ways to express empathy when you say something like, I can see how upsetting this is. I know you were not expecting this. I'm sorry I had to tell you this, but even I was not expecting this. This will be difficult for anyone, so I can understand how difficult it is. Or I was also hoping for a better result. So these are again some ways to show that you understand their emotion, you validate their emotions, you acknowledge them, and you are okay with emotions. In this situation, residents, nurses, and other paramedical staff play a very big role. Although we know the breaking of bad news has to be done by the doctors, but the milieu has to be kept very calm, wise, and the composure of the place has to be maintained. I've seen a lot of time, there's a death in the emergency department, but all other functionaries are just not affected by them. They are talking, they are laughing, they are playful. I've even seen residents telling a patient's family, patient who just died, deceased family, saying, please go outside and cry. There are other patients, we can't disturb. I've also seen, people standing at the doctor's station or the nurse's station and discussing about food. खाना कहाँ से मंगवाना है? आज वहाँ की बिरयानी मंगवाते हैं, वो बिरयानी बहुत अच्छी है. I'm not asking you to, stop your life or start crying with them. But I think understanding the sensitivity of this situation, can we stay calm and little quiet at that and appear little serious in that situation? I remember when we were kids and whenever there was a death or some serious situation in the neighborhood, Our parents never allowed us to have the TV on, or the radio on from that day or for the next few days. Because that's a way to show that we are with you in your tough time. Similarly, for example, in ICU, if there's a patient who's in critical condition and we know this patient is not going to make it, it's very important that nurses and residents are more, considerate with the family. I'm not saying allow all relatives to walk in and walk out of the ICU, but can the immediate family members be allowed to visit the patient very frequently? Like Dr. Nirankar was sharing, that we even allow the family to sit with the patient, because we know these are the last few minutes the family can see their patient alive. So these are few ways I think we need to sensitize our nurses, residents, and the other paramedical staff. The security guard, even they should know that this patient is serious and their family has to be handled with care. Now, coming to the clinician's perspective, I know breaking of bad news is very tough, and we normally call, emotionally it's very overwhelming for anybody. So it's very important to understand that it's not easy thing to do. So somebody can be uncomfortable about the patient's expectation. They were not expecting something. For example, the whole period that we did, if everything was fine and we never said it's a high risk pregnancy, and all of a sudden something like this happens, definitely to announce something like this will be very challenging. Then there's a fear of destroying the patient's home. Feeling of inadequacy in the face of uncontrollable disease. So we know that the patient has already, metastasis. It's beyond control. So you feel helpless and inadequate in that situation. And a lot of time we are not prepared to manage patients and families' emotional reaction. I've particularly written anticipate. That means please remember emotional reactions are part of the process. So we can't say, I'm not ready to handle it. And then sometimes we paint a very, optimistic picture. And when the results don't come as expected, we feel very embarrassed. I remember one of the eye chain in Delhi had this tagline, घर से आइए, surgery करवाइए, office जाइए. It is come from home, get the surgery done, and go to your office. That means you don't have to go home to take rest. You can resume your work. But I'm sure after a few cases of nucleus drop or uterus hemorrhage, I must have realized that not all cases will go to office. And then this tagline was kind of removed from their advertisement. So it's very important that we don't paint a picture where we say everything is fine. Even an OPD procedure would have some amount of risk. So how do you prevent these things? Please give realistic expectation. Accept your professional limitation. Learn to control emotional reactions. It's very important that we learn to handle emotions. Keep the family updated. If you're keeping them in loop, if you're preparing them, they're less likely to be aggressive with you, because somewhere they have already got ready for what is coming. Then, of course, document all communication. Whatever communication you make with the patient and the family, make sure you document every communication. Write date, time, the person with whom you communicated, sign it yourself, ask a family member to sign, so that tomorrow they can't say that you did not inform us or you did not keep me updated. So common mistakes that we do in breaking the bad news are, one, we avoid to break the bad news as long as possible. Either we are too scared to handle it, or we think things might change. So why tell about this? Or sometimes people think, let my next staff do it. Or I'm going to get off. So let my next ICU in charge come and do it. So you hope that someone else will have to do, and I can escape the discussion. A lot of time people don't tell the truth. They don't lie, but they don't tell the complete situation. They sometimes deliberately don't pick the patient cues because they don't want to acknowledge and address them. A lot of time this activity is done in a mechanical manner, and they may sound detached or very cold or insensitive. And as a result, the family or the patient might feel very disappointed with the exercise. So once you break the bad news, the patient might feel hopeless. They may feel that they are going to be abandoned. It's very important to now sit and prepare the strategy for the future. Maybe you are going to, treat the patient here, or you need to refer the patient to another specialty or another hospital. So it's important to reassure them that they are not going to be left. Establish a plan with them. Discuss that plan. Let them know what you're going to do. Whatever their current symptoms are and that need to be treated, they need to be handled and managed. Discuss what is the next treatment plan, and also establish a time for a follow-up. Maybe even when you refer them, you may want to come back to you for a next visit or a follow-up. You can always give them kind of inform them that they can come back to you and discuss the situation. Not that because you have referred them to another doctor, so you are no more responsible or you are not more available. So make sure that you arrange for appropriate referral, where you kind of not only just write the referral note, but you also, if possible, contact the person to whom you are referring, brief that person telephonically, inform that this patient is sending to you, and also give contact details of the person to whom you are referring to the patient and the family. In between, it's helpful to involve, people who can provide emotional support, especially like family, friends, social worker, counselors. A lot of hospitals are now, they have a set of counselors working with them who are able to work with the patient and the family to calm down. So that's how you not just hand over the patient by writing a reference, but you properly hand over the patient in a systematic manner. So to summarize, most patients want to know about their condition or whatever their diagnosis or prognosis is. And if you are able to do it rightly, it will improve your relationship with the patient and the family. It will help them cope with the situation. It will also foster a collaborative relation, and it can prevent aggressive reaction. The spike model is also very similar. In the spike model, spikes, it is spikes. It's quite similar to 4 P's that we have discussed. Spike is setting, that means where you are going to do it. And P is, give me 1 second. So S is, everybody knows spikes. Should I write in the chat box? Can somebody write in capital spikes? So S is again the setting where you are going to do it. P is perception, that is check patient's perception, how ready they are. I is invitation. Somebody can write spikes in full form. S is setting. P is perception, where you check their perception. I is invitation, where you kind of ask them how much they want to know, whom all do they want to engage. That's more like inviting for the dialogue. K is knowledge, where you share information with them. E is emotions, where you handle their emotion. And S is strategy. So whatever plan you make for the future management is strategy.
I stand for my
I is invitation.
invitation.
Invitation. So where you are kind of in inviting them. So again, it's a Western concept. We don't invite, but in an informal way, either we can check beforehand. So when we have a discussion about your treatment and your diagnosis, whom all would you like to involve? Or how much would you like to? I know in India we don't practice that way. But this idea can help us to design something that works for our population. And there are many. But I find this 4P is more simple and more suitable to our culture. So that's why I always discuss 4Ps in detail. But I tell about spikes also, because a lot of organizations discuss spikes as a format. So this is in nutshell about breaking bad news. I know nobody can prepare anybody for something like this, but at least this theoretical background kind of prepares us that there will be a lot of emotional action. If we are better prepared, if we use empathy, if we stay calm, if we listen to them, if we allow them to vent, maybe we can handle the situation. So any questions about what we have discussed? Questions or comments or feedback? Whatever. So if no questions and no feedback, I will put the feedback form in the WhatsApp group and you can give your feedback either today evening or tomorrow. Is that okay? Shall we close this session?
Thank you, ma'am. Happy
Ma'am?
Independence Day.
Please take care of your voice,
Yeah.
You're having a very bad throat.
After this, I think I have some rest. So I'm not
Yeah.
going to sleep much
Thank you,
of-
ma'am. Thank you so much.
Thank you, ma'am. Good night.
Take my milk and turmeric with
Milk,
me.
I will. Okay.
Yeah.
Happy Independence Day, ma'am. Thank you.